Hello and welcome to a short presentation on Silver-Russell syndrome, also known as SRS. My name is Sally Majid and I'm a growth nurse specialist here at the Child Growth Foundation. So within this presentation we'll be covering and explaining what Silver-Russell syndrome is, what some of the possible characteristics of the condition are, and what management options there are for Silver-Russell syndrome. And then finally, we'll be hearing from a family and they will explain what life is like for them with Silver-Russell syndrome. So what is Silver-Russell syndrome? It was identified by two different doctors separately who 20 years after they first described it realised they were explaining or looking at the same condition. That's Dr. Silver and Dr. Russell. First identified it in the 50s. And it's usually known as Silver-Russell syndrome in Europe and Russell-Silver syndrome in the USA. It's a rare disorder and research suggests it affects 1 in 15,000 children, but the true number of people affected by SRS is difficult to determine due to the complexities of making a diagnosis. Over recent years, genetic tests have been able to identify two main genetic changes involving chromosome 7 and chromosome 11, and that's for around 60% of cases of SRS. It's on chromosome 11p15.5 where changes have occurred, causing the condition in approximately about 50% of the cases, and around 10% it's on the chromosome 7, that's known as MUPD7, and that means that the child will have inherited both copies of chromosome 7 from their mother instead of one from each parent. But of course that means that for the remaining 40%, a genetic cause has yet to be discovered, and they will be diagnosed based on how they clinically present, what kind of symptoms they have. The characteristics we'll go on to describe in more depth are the small stature and poor growth before and after birth, and a number of physical features and feeding difficulties. So the characteristics of Silver-Russell syndrome. SRS can be difficult to diagnose as features of the condition and their severity can vary greatly. So it's important to remember that the symptoms described here will not be experienced by everyone with SRS. I've split them into two, the physical features and the facial features. So the possible physical features, poor growth being one of the biggest features of Silver-Russell syndrome, and it's likely to have been identified during pregnancy at growth scans. It might have been described as IUGR, and that's intrauterine growth restriction, and then when the baby's born, SGA, which is small for gestational age. That means they'll have birth weight and length below the second centile on a growth chart. And a key feature is that they'll have no catch-up growth. Feeding difficulties can be significant, and the baby child will possibly have a very poor appetite and struggle to gain weight. And it could be further complicated by gastrointestinal issues, and these could be reflux, which may cause discomfort and vomiting. They may also have delayed gastric emptying, causing the child or baby to feel full. And there is a reported increase in issues with constipation. All of these factors may cause a food aversion. And quite often, babies with SRS will require supplementary feeding to gain weight. Body asymmetry means that one side of the body is smaller than the other side. In most cases, it could just be one arm or leg, but on occasion, one entire side of the body is affected. If there is a leg length difference, it's important to remember that when your child has their height measured, they should always be measured using the longer side. Delayed bone age is determined by an X-ray of the wrist and hand and helps doctors estimate the maturity of a child's skeletal system. If a child has a delayed bone age, which means their bones are measuring younger than their actual age, it could indicate a late growing period. However, in children with SRS at about 8 years of age, they have a period of rapid increase in bone age, and it becomes advanced, meaning that their bones are measuring older than what they actually are, and that may mean they will stop growing sooner. Hypotonia means low muscle tone and may mean that there could be a delay in reaching motor skill milestones. Delays in speech could occur, and whilst the majority of children with SRS have no learning difficulties, research does indicate that there are some difficulties experienced and that they're more likely with the children who have the genetic type of MUPD7, and they may have key features on the autistic spectrum disorder. Hypoglycemia, which means low blood sugars, it's most likely to happen when a child doesn't eat for an extended period of time. And signs of low blood sugars could be sweaty, shaky, feeling confused, having weakness, and possibly collapse. And it is known that children with SRS are more likely to have issues with hypoglycemia. And then the curved fifth finger, which is the little finger, you might have also heard it referred to as clinodactyly. So possible facial features. The first three, the shape of the face, triangular shape, a prominent forehead, and the relatively large head, are the most common in SRS. But the larger head is usually seen at birth and early years, and it's only larger compared to the child's small body. The petiteness of their body makes their head look larger, but that becomes less with age, as does the prominent forehead, becomes less noticeable. Low set ears they may have, and then the things that may affect the child's ability to feed and further complicates the feeding problems are the lower jaw that's small, the crowded irregular teeth, and the high narrow palate. And there has been some reported instances of a cleft palate as well, and of course all these things can impact on the feeding skills of the baby or child. And the last one, late closure of fontanelle. They're the soft spots that babies have on their head, and they will have all normally closed by the age of 18 months. But in some cases, they close later with children with SRS. So these are some possible additional characteristics of SRS. Early puberty, so that would be the appearance of physical changes related to puberty. And for girls, that would be before the age of 8, and for boys, that would be before the age of 9. Scoliosis and kyphosis are a curvature of the spine. Hip dysplasia is like the hip dislocation. Hand and foot anomalies, again, rarely reported, but they have researchers indicated that there is some instance of them where fingers that are in a bent position, and that might be referred to as camptodactyly. Syndactyly of the toes, which is webbing or where toes are fused, and prominent heels. Genitourinary anomalies, these have only been reported in a small number of individuals with SRS, but for boys that could be undescended testes or an abnormal placement of the urethra, the urinary opening in the penis. For girls, it could be an underdevelopment of the uterus and upper part of the vagina. Again, heart and kidney issues may only be in small numbers. So diagnosis. As I said before, the diagnosis of Silver-Russell syndrome can be very difficult because the condition varies widely in severity among affected individuals. But a group of experts on the condition have worked together and developed the Netchin-Harbison clinical scoring system. And they recommend that SRS should remain a clinical diagnosis, so based on the symptoms presented. And they've produced a list of six possible symptoms for giving a diagnosis of Silver-Russell syndrome. To have a diagnosis made, an individual must have 4 of the clinical criteria. and 2 of them must be the prominent forehead and the relative macrocephaly, macrocephaly being the larger head. This is because other conditions present in the same way as Silver-Russell syndrome, but the relatively larger head at birth with a protruding forehead alongside these other symptoms are specific to Silver-Russell syndrome. And if a child has 3 out of the 6, then it's still recommended that a genetic test be carried out. So possible treatment options. Feeding support, early support with feeding challenges is essential, not only to establish optimum weight gain and growth and overall health, but to minimise the stress and impact emotionally on the whole family. The pressure on parents trying to ensure that their baby with SRS is fed and nourished cannot be underestimated. Assessment and treatment for any issues with reflux or the delayed gastric emptying and constipation should be considered, and as should any issues with oral motor skills and sensory problems that might affect oral intake. If there are cases of extreme feeding difficulties or reflux, it may be that the child or baby needs supplementary feeding with a nasogastric or a gastrostomy tube. A nasogastric tube is for a short-term basis and is inserted via the nose into the stomach, and it's for additional nutritional support. A gastrostomy tube is inserted surgically under anaesthetic into the abdomen, and it's for longer-term use. Nutritional goals for the first few years of life are to ensure adequate nourishment, but that should be carefully monitored. Weight gain should be carefully monitored because of the risk of metabolic syndrome in later life, and that could create problems such as obesity, high blood pressure or cholesterol, and type 2 diabetes. Hypoglycemia. So children with SRS do have an increased risk of fasting hypoglycemia, particularly at night time. And your healthcare professional should discuss with you what kind of assessment, monitoring or treatment plans they will put in place if this is of a concern. But it should definitely be considered if your child is unwell with tummy bug and not tolerating foods, or if they're having an operation and is nil by mouth. A plan should be put in place to ensure there's no hypoglycemic episodes. Growth hormone therapy is recommended under the small for gestational age guidance, and that's from the age of 4, and it's once any calorie deficits are addressed, and it not only has benefits to improve growth and final height, but also the potential benefits are an increase in appetite, an increase in lean body mass and muscle strength. Assessment for issues with limb and skeletal problems should be something that's initiated as soon as symptoms are evident or on diagnosis of Silver-Russell syndrome. Orthopedic management may be required for any body asymmetry or leg length discrepancy and scoliosis. And they will also assess for the other occasional characteristics that we described, such as the hand and foot problems and hip dysplasia. Treatment of early puberty. If treatment is required, then it's likely to be in the form of a hormone treatment aimed at suppressing puberty. So management of Silver-Russell syndrome is completely dependent on which features of the condition affect the individual. Remember, frequency and severity of each characteristic can vary greatly. The main therapeutic goals up until 2 years of age is nutritional support to recover any calorie-related length and weight deficit and to prevent any hypoglycemia. And this diagram shows you which healthcare professionals might be involved in managing the possible health problems. There are a number of specialist medical professional therapists to support you and ensure your child is well and reaches their full potential. And lastly, here at the Growth Foundation, we are happy to answer any queries or concerns you may have, so please feel free to contact us. We can also put you in touch with other families who are going through or have gone through the same challenges as you.
Hi, my name's Catherine. I'm mum to Jessie, who is who's got Russell Silver syndrome, 11p15. Jessie is nearly 9 and was diagnosed about 5 years ago. Yeah, we had quite a long road to diagnosis. He was very poorly as a baby and always in hospital, and every time we went into hospital, no matter what we were doing there, whether it was breathing treatment or steroids or feeding tubes or one of any number of things that we were there for, I don't think we went to A&E without somebody ever commenting on how small he was, or coming back to check that he was definitely the size that they had weighed him to be, or that he was the age that they put him down for, because he looked so much smaller. And one time we even had someone come and compare their newborn with Jessie, who at the time was 9 months. So yeah, there was just lots of comments about it, lots of acknowledgement that he was very, very small, but just nobody ever kind of made a link really between the symptoms he was exhibiting and his size. So we were under general peds as well as loads of other medical teams for quite a long time. I think we were discharged from general peds in the July before he went to school in the September, and then the school nurse came into school and did the standard measurements, and obviously he was way under the growth charts for height and weight, and so we were referred back into general peds. And at that point the consultant just decided that there was definitely something more going on with him, and that it was time for them to kind of look into this. And her feeling at the time was that Jessie had growth hormone deficiency. So we were referred into the endocrine team, and we went along for the appointment expecting that what would happen is that we would be given the appointments to go and measure his growth hormone to check that was, or to confirm really that wasn't working or producing enough. I'm not sure what the right term is, but actually what happened is that we walked into an appointment and the consultant started to ask me what felt like really bizarre questions about Jessie's hands and toes, and he already knew that he had some body asymmetry before he'd even asked me. He noticed his ears and his head. He asked me whether he was a very sweaty baby, and I of course said yes, and told him that GP had noticed that his heart had been looked at to check that was okay. And he seemed to just know all of these things about Jessie without anyone ever having told him about them. And at the end of the appointment, he just said, I don't think that he's got growth hormone deficiency. I think that he has got something called Russell Silver syndrome, which we'd never heard of, weren't expecting. And so that was, yeah, just a massive unexpected curveball really. So we left the appointment having the next step being referred to genetic doctors to go and have some genetic testing done on Jessie, which obviously happened, and we found out a few months later that he'd come back positive, not sure that's the right word either, for Russell Silver. On hearing the diagnosis, I think, we were upset for him and sad that for what it might mean for him, but just really vindicated too, in feeling like all of that time spent in hospital was, it wasn't just us thinking, why does this keep happening to him? This can't just be asthma, it can't just be small lungs, it can't just be that we're waiting for him to put on a bit more weight before he can breathe properly. Yeah, there was definitely a sense of just feeling like my instinct was telling me there was something more, and to hear that vindicated there was a satisfaction in that, and a relief really, to know that there was something that was causing this, that at least now we can get on with understanding and treating. I think Jesse wasn't that bothered. He was sort of fairly happy with what we told him. I suppose the biggest thing for him was that we'd gone back to school in the September of his year one year, and he started that year kind of top of the class, really bright little boy. And a couple of weeks in, his teacher came out and said, "Oh, I'm a bit worried about him. He seems to be struggling quite a lot. Has he been poorly again?" And he hadn't actually been, he'd been fairly well. And so that was like the September. In the October, we'd had his confirmation of his diagnosis, and by Christmas, his teacher had come out and basically said he just wasn't coping anymore and he wasn't keeping up, and that the demands of the school day were just obviously massive for him and too hard. And they were having to spend a lot of time at lunchtime making sure he was eating, and when he was on the playground, I think they just felt really worried about him because he was very small. And again, he wasn't that bothered. He wasn't scared to go and play or anything like that, but we could see that the toll that school was taking and what it was taking out of him every day to have to keep going and giving out. And I think particularly difficult was when he realised that he wasn't in the same groups anymore. I think he was aware that he'd been doing quite well at school and now he was really struggling at school. And I think it was in his head. He knew everything, but he just couldn't write anymore, or he couldn't write enough anymore. And that's definitely something that's gone through school with him. That has become harder and harder as he's gone further and further up the school. And just recently, he's basically stopped writing really now, and he does everything on his computer, his laptop at school. So he's been really well supported by the OTs from our children's hospital, and there's been a really big dip, but that's really helping to bring him out the other side. I think other ways it affects day to day is that, again, that fatigue has stayed with him, that the fatigue I think that he feels is quite different to that of his siblings, such that sometimes he on a Friday at the end of a quite hard busy week at school, all his siblings will be playing, and he'll play by sitting down, but he'll join in kind of from a sitting position. So if they're throwing a ball, he'll always be lying down under a blanket. There's times, obviously, where eating is just too much. So I would say that's probably the hardest thing for him. I think more and more the reality of how small he is it can maybe feel harder and harder sometimes at clubs. Doing things like swimming is really, really difficult, and often can just result in him not really just wanting to, because he kind of knows that he's just not going to be able to keep up, and that can be quite difficult to watch. But we've had some really good advice in just trying to find activities that don't require like racing, and where being small can be an advantage. So he does like a karate lesson where there's an emphasis on flips and jumping around basically, and that's great, because actually being small and being quite good at bending yourself into weird positions is quite a good thing. So yeah, I think that's kind of the day to day from that point of view. I think the medicines, obviously he has a daily injection. He has quite a lot of other medications. So I think he has about 8 medications every day, and then his injection for other issues that he has alongside Russell Silver, and they can really take their toll. I think that there are times when he just doesn't want to do it and just wishes it wasn't him, and will say things like, I'm just happy being small, please don't make me have my injection tonight. And so there can often need to just be quite a lot of conversation, a lot of work around why we think that the injection is the best thing for him. And while it can feel really hard now, in the future he'll be really glad, well, we hope that he'll be really glad that he's had it, and it's making him stronger every day. And I think because he was that bit older when he was diagnosed, we can tell him, and he can remember when like breathing was really hard, and how much easier that's become with growth hormone as it's become more effective. I think hopes for the future are the same as our hopes for the future of our other children, that Jesse will grow up and that he will know who he is and be content with who he is, that he'll find passions and loves and be able to pursue those, whether he's small or not, whether the growth hormone stops working or not, that he'll understand his worth and value is bigger than the way that he looks or the size that he is. And that, I suppose that's very long term. In the more immediate, I think we're really grateful that he's with a really great group of children at school. He's got really good understanding friends who are really supportive of him. He's in a really good and supportive school. And so I suppose at the moment our hope is that he just manages to keep being part of school, that he's able to keep going along to those things, that he's able to keep managing and succeeding. And I suppose that he's able to do his best, and there's accommodations are able to be made for him to do his best when he can't necessarily show his best through the traditional means. Any advice would be that, first and foremost, to speak to the Child Growth Foundation. And I've found just being part of the Facebook community really helpful, and certainly going along to the first convention was really, I remember walking through the doors of the hotel and just bursting into tears, seeing all these little children that looked just like Jesse looked, and I think I found it overwhelming, but at the same time I found it just deeply comforting that there are other people, that there are other people out there that are dealing with this, who are that bit further on, and can just kind of help with understanding the condition a bit. And some of the Zoom coffee groups have been really great as well. I think at one of the ones there was a girl who's at university now, and she talked about how painful she used to find writing, and explained it in a way that she could explain it because she was that bit older. And that's something that, like, Jesse has talked about a lot, and when we've tried to understand why it's painful, for example, what it feels like, he can't really tell us. But yeah, just being able to hear it from someone who's that bit older and can remember what it was like and how it felt, was just really useful for us as parents to understand what he was having to go through. So yeah, my advice would be, number one, Child Growth Foundation, find some other parents and come to the convention. I think hearing from the experts has made me much more confident going into medical appointments, and the depth that they go into in some of those seminars about things like what blood tests should Russell Silver kids be having every year, and the stuff about like the bone age, which I didn't really understand, and we'd been told wasn't really important for him, for us to track. And obviously we found out at the convention that that actually it's really important, and we were able to understand why and then explain that, and it was fine, so then it was done. But I think, yeah, finding experts in the condition when you don't have that level of expertise at your local hospital, again, has just been hugely beneficial. Yeah, and I think my other advice would be to find a good teacher who will do things like make sure your kid can open the door at junior school because they're so much heavier, and will tell you when they can't really sit down on the chairs because they're too high. Yeah, I think the teacher plays a massive role in the life of a kid with Russell Silver, particularly if your child's like Jessie, where the needs aren't necessarily obvious, and the child definitely isn't going to go and tell the teacher that they need some help. I think there does need to be an intuition there, so that there is a bit of looking after, without it being like too much or too obvious, or not allowing them to still just be a kid in the class. So I think we've really appreciated the teachers and the TAs who have just been quite intuitive about what he might need and haven't made a big deal out of it. And Jessie has like some seating at school and some extra foot boxes and things so that he can sit at the table properly. But every morning they're put in for him ready, so no one really sees. And if they're ever going to go and sit anywhere else, they're taken along but just slipped in really quietly. So I kind of know that he's always being looked after without it being too over the top or hysterical. So I think that's probably the best way to deal with it, is to be realistic when there is a need that needs to be met, but not to take it to such an extreme that they're not still just allowed to learn how to cope with just who they are. And that's true for every child, but for Russell Silver children, it might just be it's learning how to cope with just being a bit smaller than everyone else or a bit weaker. So yeah, I hope that's okay. Thanks. Bye.